Today the topic of our discussion is oral pre-malignant lesions and conditions or potentially malignant disorders. I am Dr. Annapurani from Department of Oral and Maxillofacial Surgery. WHO in 2005 have redefined all the oral lesions with the potential for malignant transformation into a group called as potentially malignant disorders. The initial terminologies like pre-malignant lesions and pre-malignant conditions are abandoned. They are clubbed into the same group now. So the following are the lesions which come under that. Those are leukoplakia, lichen planus, erythroplakia, erythroleukoplakia, erythroplakia with ulceration, proliferative verrucous leukoplakia, and oral submucous fibrosis. Oral lichen planus. Oral lichen planus is a complex chronic inflammatory disease that affects about 1 to 2% of the population. It can happen in oral cavity as well as in the cutaneous tissues. Though the etiology of oral lichen planus is unclear, there are evidence saying that it is an autoimmune disease. That too, it is a T cell mediated autoimmune disease. The malignant transformation of oral lichen planus is quite low, that is it is less than 1%. So it shows it's a low risk lesion. Clinical features includes it can vary from a small minor keratosis. Its presentation can vary from a minor keratosis to erythroleukoplakic form, that is mixture of red and white patches, or it can even have a ulceration on that along with or without cutaneous manifestations. Typically you have four types of clinical patterns in that, that is reticular, erosive, plaque-like and bullous. Reticular type has the typical lazy network. Lazy network, that is this is the crisscrossed lazy network pattern is seen in the reticular form of oral lichen planus. This is named as Wickham's striae. This is an important term you should remember. Wickham's striae. This white lazy form seen in lichen planus is called as Wickham's striae. This is not a patch one. This is a white lazy pattern. Just remember this. Erosive lichen planus appears as a ulceration with a whitish yellow pseudomembrane, and plaque-like lichen planus has a typical whitish raised lesion which cannot be rubbed off from the tongue or buccal mucosa easily. Bullous lichen planus is a very form and it is characterized by the large bulla most commonly seen in the posterior buccal mucosa. So you can remember the physical forms with the name. Reticular has a lacy format. Erosive lichen planus has a ulceration. Erosion means ulceration with a whitish pseudomembrane. In ulcers you have pseudomembrane, and in case of plaque, like what does a plaque mean? You have accumulation of whitish features, that is plaque like. You have a typical whitish raised lesion in case of plaque like lichen planus. Bullous lichen planus shows what does a bulla mean? It is a small liquid filled lesion. So you will have a large or small bullae in case of bullous lichen planus seen in the posterior buccal mucosa. The management includes, first we should confirm the diagnosis with a biopsy, because plaque like bulla and ulcer, all these presentation can be something else also. So first we have to confirm with the biopsy. When we get the result of oral lichen planus, then the first line of management in case of lichen planus is symptomatic relief. As we all know, the rate of malignant transformation is very less. So we can concentrate first in the symptomatic relief for the patient. In case of persistent painful lesions where the topical steroids is not are not helpful, we can go for a short course of systemic steroids also. Leukoplakia. Leukoplakia can be defined as a white block of questionable risk having excluded known diseases or disorders that carry no increased risk for cancer. To put it in simple words, this is a white block and which is excluded, that is you have a list of lesions which doesn't carry, which is also white in color, but which doesn't carry any risk of cancer. So this must be excluded of that, and it also has a questionable risk in relation to the patient's history. So what are the, first we should know what are the white lesions without any risk, increased risk of cancer. So those are candidiasis, frictional keratosis, hairy leukoplakia, Fordyce granules, leukoderma, linea alba, white spongy nevus, nicotine stomatitis, and chemical burn. So these are the group of lesions which are white in color, but they have a proper reason, known reason for their occurrence, and they don't carry any increased risk of malignant transformation. So if you have any white lesion and you cannot classify that, put that lesion into any of these group, and the patient's history also shows increased risk towards any malignant or pre-malignant condition, then you can name that condition or lesion clinically as oral leukoplakia. So the main etiological agent for leukoplakia is tobacco, but there is a strong evidence to connect it with the use of alcohol, because alcohol and tobacco has a synergetic effect. So whatever tobacco is going to do, alcohol has a tendency to amplify it. In 1980, WHO has classified leukoplakia into homogeneous and non-homogeneous groups. As the name says, homogeneous is, it is uniform. It is not going to have any uh, what to say, change in color or structure in that. So it is flat, thin, uniform white lesion. It can be further divided into, the uniformity can be smooth or fissured or ulcerated. In case of non-homogeneous leukoplakia, it is described as white and red lesion which is irregular or nodular. In 2005, there is a WHO gave another separate histology classification for the clinical leukoplakic lesions. So that can be mild, mild dysplasia, moderate dysplasia, severe dysplasia, carcinoma in situ. According to this histological grading, we can estimate the stage or severity of the lesion. Carcinogenesis developing from oral leukoplakia is characterized by progressive loss of proliferation and apoptosis controls, and increasing cellular disorganization, aneuploidy, and heterogeneity. Management of leukoplakia usually begins with the removal of source of the lesion. What is the source of the lesion? Tobacco usage. So patient must be put on a tobacco cessation program. After 2 weeks, the lesion must be reviewed to see for any change, reversal changes in the lesion. If there is no change, then a definitive diagnosis must be obtained by taking a biopsy. Biopsy of the lesion classifies the leukoplakia into dysplasia or non-dysplastic leukoplakia. What could be a non-dysplastic leukoplakia? It can be any hyperplasia or any other lesion. So in case of non-dysplasia, then it shows it is very less severe. So it can be followed up at an interval of 6 months. Mildly dysplastic lesion can also be grouped into this, that is, it can be followed up for once in 6 months. But moderate and severe dysplasia are having little increased chance of malignant transformation. So it's better to go for a complete excision or a serial excision or laser ablation to eradicate the lesion. Once excised, still the bed from where the lesion was excised should also be monitored closely for every 4 to 6 months to not to miss any recurrence of leukoplakia or not to miss any malignant transformation from the leftover tissues. Erythroleukoplakia is a red lesion that cannot be classified as any other entity. Such lesions have a flat, macular, velvety appearance and may be speckled with white spots representing foci of keratosis. In the given picture, we can see a white lesion with a red color lesion in the center. Again, the red color lesion is having a ulcerative spot in its center. This is one of the presentation of erythroleukoplakia. Clinical features. Erythroleukoplakia lesions usually present as solitary lesions, unlike erosive lichen planus and erythematous candidiasis. Why are we giving it along with erosive lichen planus and erythematous candidiasis? So both these lesions also have a red color presentation. Erosive lichen planus means there will be an erosion which can be ulceration, so it will mimic, or clinically it can be confused with erythroleukoplakia. The same way, erythematous candidiasis is also a kind of atrophic candidiasis where the lesion is red in color. One clinical way how we can differentiate is it won't be spread over the entire buccal mucosa like how lichen planus or erythematous candidiasis can present. It will be seen as a solitary patchy lesion, which is a lesion confined to over a small place in the buccal mucosa or any other specified region. It won't be spread out, it will be a solitary confined lesion. Red lesion without a white component may also represent dysplasia, carcinoma in situ, or a carcinoma itself. So such lesion must be carefully evaluated and most preferably completely excised. Carcinogenic progression in patients with erythroleukoplakia has been shown to be almost fourfold than that of the patient with homogeneous leukoplakia. Treatment of erythroleukoplakia is usually by excision or by laser ablation. It is prudent to continue to follow the patients periodically to ensure no recurrence of erythroleukoplakia or conversion to carcinoma. Oral submucous fibrosis. Oral submucous fibrosis is a disease of oral cavity resulting from inflammation and progressive fibrosis of the submucosal tissue, resulting in significant rigidity and inability to open mouth. So, the name itself says oral, which involves oral mucosa, submucous, that is whatever the changes present that have happened just beneath the mucosal surface. Fibrosis, what kind of change have happened? That is the submucous structures have undergone increased fibrosis. The most common site involved is the buccal mucosa. However, any component of the oral cavity can be involved. Aricolin, an alkaloid found in the areca nut, promotes salivation, which it also stains the saliva red, and it is a stimulant for the increased fibrosis. There is a direct dose-related response of the development of submucous fibrosis, frequency and duration of the habit of chewing areca nut. Aricolin can promote fibroblasts to increase collagen in the submucosa by 150%. Clinically, oral submucous fibrosis is characterized by a burning sensation with stiffening of oral mucosa and oropharynx leading to significant trismus. More often, in case of advanced oral submucous fibrosis, the fibrosis may extend from the buccal mucosa to the oral commissure also, which will even make the oral commissure small. The fibrosis and hyalization occur in the lamina propria with resultant atrophy of the epithelium, leading to predisposition to the development of squamous cell carcinoma. The predominant goal for treatment of oral submucous fibrosis is to improve their mouth opening. Minor cases or less severe cases can be managed with intralesional steroids in combination with hyaluronidase. The name suggests hyaluronidase, that is, it is a breaker of it leads to enzymatic breakdown of ground substances which will be present abnormally increased in case of submucous fibrosis. We can also use placental extracted antibodies to inject intralesionally to promote fibrinolysis. Interferon gamma also plays a role in treatment of oral submucous fibrosis due to its immunoregulatory effect. The same way, placental extract also has a immunoregulatory effect through its antifibrotic cytokine. Surgical treatment is needed in case of severe cases where the medical management fails or inadequate to achieve the desired mouth opening. It can be done by fibrotomy, that is surgically we will break the submucous fibers. Mouth opening will be attained with active mouth opening intraoperatively. Then there will be a gap, there will be a defect present, which will be reconstructed with buccal fat pad, or we can even use local flaps or a free flaps. Flaps in the sense we will take tissue from the same patient, either from the nearby region or from the distant region. If it is going to be from the nearby region, we'll call it a local flap. It can be from the nasolabial flap, nasolabial region. That tissue can be used, which will be called as nasolabial flap. And if the distant tissue, if the tissue we are taking it from the distant region to reduce the scar and to improve the aesthetic outcome of the patient, then it is called as free flap. Even despite these treatments, oral submucous fibrosis can recur if we fail to give continued physiotherapy. So physiotherapy is needed. However, the treatment is done either medical, surgical, in surgical, whatever flap we are going to use. Proliferative verrucous leukoplakia. Even though if this is a leukoplakia, we are keeping it in a separate chapter. That is for the upcoming reason we'll discuss it. The name is due to its characteristic appearance. It is an expanding exophytic. That's why proliferative, that term is given. Verrucous, that is the nature, fissured kind of or irregular surface. That verrucous term gives you the irregular surface nature of the lesion, and a white lesion, that's why it's called as leukoplakia. It is a very high risk precancerous lesion with a high transformation, and even after transformation, malignancies which have transformed from proliferative verrucous leukoplakia has very high mortality rate. Causative factor for proliferative verrucous leukoplakia have been found to be human papilloma virus, whereas for normal leukoplakic lesions it is tobacco usage. It can be with or without alcohol. The mechanism of carcinogenesis in case of proliferative verrucous leukoplakia is modulated via the human papilloma virus subtypes, that is 16, 18 and 31. These are found to be associated in the pre-malignant and malignant lesions in the oral cavity. HPV virus manifests itself primarily in the posterior regions of the oral cavity, that is base of the tongue, oropharynx, tonsils and tonsillar pillar. HPV positive group is the fastest growing segment in the oral cancer population, yet many of us are unaware of it. The treatment of proliferative verrucous leukoplakia usually involves surgical excision and also use of a carbon dioxide lasers. Unfortunately, the lesions tend to recur and have to be excised or undergo repeated laser ablations. Topical photodynamic therapy also may proven to be useful. It causes a relatively low morbidity and no scarring, and multiple mucosal sites can be treated simultaneously. In spite of this, patient has to be followed post-operatively to keep a check on recurrence or any malignant transformation of the residual lesion from the leukoplakia. We have come across the most common potentially malignant lesions. When we, in a general overview, when we get a lesion, suspicious lesion, this is the algorithm for diagnosis. That is, first we should red or white lesion. First we should see the site, size, sex, color, how is the texture, and what are the risk habits, that is patient's history. With that we can classify it as potentially malignant or non-malignant. So if the site and sex, that is it is in the buccal mucosa, size is completely in the or the entire stretch of buccal mucosa. If it is scrapable, then it is a non-malignant lesion. It is going to be candidiasis. Then if it is going to if the whiteness of the lesion is going to fade away when the mucosa is stretched, then it is leukoedema. Again it is a non-malignant lesion. If the site and size as well as the risk factor falls into the leukoplakic group, that is you are not able to put the lesion into any known diagnosable white lesion which doesn't carry increased risk, then we will group it into potentially malignant lesion. In that again we have a low risk lesion, high risk lesion. What is a low risk lesion? Lichen planus can be a low risk lesion. So for that you should remove the local irritant. If there is any impinging tooth is there or anything which can provoke a lichenoid reaction, any restoration in the tooth which is provoking the lichenoid reaction, we can remove that. We can treat it symptomatically and then it can be reviewed after 2 weeks. If the lesion is going to persist, then we can take a biopsy to confirm the histopathological nature of the lesion. If the lesion is going to regress, then it is not even a lichen planus. The white lesion could be a lichenoid reaction due to any changes. It can be due to any use of chemical or due to any non-compatibility with the restoration we have done. What is the high risk lesion? If there is a white patchy lesion which cannot be classified into any other low or non risk lesion, then we will consider it as leukoplakia. And what are the reasons for leukoplakia to occur, for a normal leukoplakia to occur? That is tobacco usage. So we can advise the patient to discontinue tobacco usage for 1 or 2 weeks and we can review the patient. If there is regress in the lesion, then we can wait and watch. But if the lesion is going to persist in the same way, then a biopsy is needed to know the histopathological nature of the lesion. What can the biopsy say? It can say whether the lesion is having hyperplasia of epithelium or dysplasia or carcinoma in situ, or whether it have already turned to a carcinoma. In case of red lesion, again the same thing. For red lesions or for a proliferative varicose leukoplakia, we need not wait at all. That is, on the day we see the lesion itself, it is considered as high risk lesion, and biopsy must be done as early as possible to know the histopathological nature. Then, if it is haven't transformed, if there is no evidence of any malignant transformation or a carcinoma in situ, then we can go for a wide local incision or a serial excision to get rid of the lesion. And in any case, whether it is high risk or low risk, biopsy is done, total excision is done. Regular follow-up is needed to confirm the recurrence of the leukoplakic lesion, erythroplakic lesion, or any malignant transformation. So all these patients has to be kept under observation for next 2 to 3 years at a regular interval of 4 months or 6 months. And management, as I have already told, we are taking a biopsy in a high risk patient. On the day patient presented itself, it can be moderate dysplasia, severe dysplasia, or carcinoma in situ. What we will do? Carcinoma in situ can also be treated as a severe dysplasia. So we can do a wide local excision or a laser therapy, cold knife, that is I'm not getting the name suddenly. Photodynamic therapy. In case of low risk lesion, that is white patchy lesion which have regressed a little bit but still persist after removal of the source of irritation, or lichen planus, the hyperplasia, hyperkeratosis, it can show hyperplasia, hyperkeratosis, mild or no dysplasia. Then we can remove that time. Excision is not compulsorily needed. We can remove the local irritant factors, keep the patient under follow-up. In follow-up, if the patient is going to show any clinical progression, there is a recurrence or there is any other change, then we have to again do biopsy. This is the algorithm how we first identify the lesion and how will we grade the lesion to high risk or low risk, which patient should have a waiting period for 2 to 3 weeks after removing the foci of irritation, which patient should go for immediate biopsy, and with the biopsy who can go for excision and who can be under follow-up. To concise in total, the treatment options for oral pre-malignant disorders is potentially malignant disorder is habit cessation, surgical removal, systemic medication, topical medication, photodynamic therapy, and a combination of all. So mostly You have a chance of getting this question in a short essay or a short note only. So first, your question paper will get it like pre-malignant lesion or pre-malignant condition. But you say in 2005 WHO have a changed the nomenclature into or potentially malignant disorders. Then you can enumerate the lesions. You can enumerate 4 5 lesions, and in every 4 5 lesion, each lesion you give 2 3 clinical features. The clinical features are going to be similar with the minor changes from one another. Then you say the what is the risk of malignant transformation for each. Some will carry low risk, some will carry high risk, and a specific what is the causative agent. Then what is the line of treatment? First, what we will do, almost for everything, the first treatment is removal of the foci of irritation, then follow, then biopsy. This is the concised management for oral pre-malignant lesion. If you are going to give this overview and write a overview for individual lesions, and then write a total algorithm of diagnosis and total algorithm of management for oral pre-malignant lesion, then it is all good enough for a short essay. Thank you.